Good afternoon. Oh. Always wanted to do that. Good afternoon. I'm Randy Siebel, president of Better Health Greater Cleveland and a general internist at Metro Health. Metro generously serves as the administrative home base for Better Health Greater Cleveland and is a founding Better Health member, along with the Health Action Council of Ohio, the region's voice for purchasers that offer health benefits to employers, employees, their dependents, and their retirees. So thank you very much to both of those organizations. Now it's my personal pleasure to introduce Mr. Greg Moody, Director of Governor John Kasich's Office of Health Transformation and member of the Governor's Cabinet. Governor Kasich appointed Greg to lead the Office of Health Transformation in 2011, and from that point on, and I can say with personal experience, the state was off to the races. The Office of Health Transformation was assigned responsibility for advancing the governor's Medicaid modernization and cost containment priorities and engaging Ohio's private sector partners to improve overall health system performance in the state. Mr. Moody was well prepared for the task, having served as a senior staffer for the U.S. House Budget Committee, whose chairman at the time was Representative John Kasich from Ohio. Mr. Kasich asked Greg to study the impact of Medicaid on federal spending, which was an assignment that set the course for the rest of his policy career. Most pertinent to today's presentation, Greg has led the state's initiative to obtain broad support for the reform of healthcare delivery and payment systems. Our current healthcare system pays healthcare providers for treatments, tests, and procedures with no accountability for outcomes. In 2011, Governor Kasich issued an executive order to, quote, engage private sector partners to set clear expectations for better health, better care, and cost savings through improvement, end quote. The Office of Health Transformation is resetting the rules in Ohio so that the incentive is to keep people as healthy as possible, pay for what works to improve and maintain health, and shift away from fee-for-service payments to population and value-based payments that reward patient-centered care. And in contrast to years that I have experienced that the state has intended to switch to payment systems rewarding value instead of volume for healthcare services. Under Greg and the Office of Health Transformation's leadership, it is underway, starting with using Ohio's purchasing power for 2.8 million of our 11 million citizens to leverage support from Ohio's largest commercial insurance companies. I'm pleased that Better Health Greater Cleveland has been part of this process and delighted to have Mr. Moody share the state's strategy in Ohio's plan to transform payments to improve health. Ladies and gentlemen, members and guests of the City Club, it is my pleasure to introduce today's speaker, Mr. Greg Moody. Greg?
Well, thank you, Randy. You somehow got a hold of the first 2 pages of my speech. So I'll skip ahead and we'll be done on time. Thank you for the invitation to join you to talk about Ohio's health transformation. It's a humbling thrill for me to stand on this great City Club stage. I'm glad for the many familiar faces that are here. Many of you in this room are as qualified to share these thoughts, but I'm glad to speak for our work together to improve overall health system performance. Governor Kasich spends a lot of time in Cleveland because he feels comfortable here and because he respects the way this community works together to solve problems. He's been proud to support your work to reform your schools through the Cleveland Plan and holds it up as an example as he travels the state of the good things that can begin to happen when communities come together to put kids first. He's also very proud of what's happening with the Opportunity Corridor, a real opportunity for the state and community to partner to restore vitality in neighborhoods that haven't gotten the attention they deserve, and to make sure residents in those neighborhoods benefit directly from that work. Communities that can come together to overcome obstacles are stronger and can draw strength from past successes to carry them through new challenges. I saw that strength firsthand several months ago when we had the Ebola scare. Healthcare systems here that on a normal day are locked in bitter competition, I won't name names, many of them have tables, came together with local public health leaders like Terry Allen and put together a plan to share services in a way that will serve as a model for the nation. The thing is, that is not new. Several years ago, the health systems in this area put aside the normal arms race of everyone needing to be the best at everything and together invested in a trauma network that makes this community safer in its greatest times of need and, by the way, saves money. And there's one other collaboration I want to specifically mention. Metro Health stepped forward 2 years ago and ahead of everyone else used county money to extend Medicaid coverage to very low-income uninsured residents. That was a real leadership moment because there was doubt about whether or not expanding Medicaid was the right thing to do. What did we learn from the Metro experience? Many of the enrollees were working poor. Nearly 1 in 4 needed behavioral health services. Outcomes were better. Diabetes, blood pressure, hypertension, all improved. Costs were lower. Emergency department utilization went down, and 4 out of 5 were connected to a medical home. Overall, costs came in $42 million below budget. I'm pleased to report we are starting to see similar results in the statewide expansion. And due in large measure to the good work by people in this room, more people, including legislators, understand that coverage works. On Monday, Governor Kasich will introduce his 3rd budget. It might surprise you that the Medicaid expansion is not in there, because it doesn't need to be. Current Medicaid eligibility levels went into effect in October 2013, and that authority does not expire. Expanding more, or taking something away, that requires legislative action. But the benefits of the expansion are clear, and the governor supports the current levels, so the budget as introduced will be silent on this issue. But let me be clear, the budget is not silent on reform. No Kasich budget could be. It will rebuild community behavioral health system capacity, give people with disabilities more opportunities to live and work in the community, tighten up oversight in home health care, invest in primary care, and hold down overall Medicaid spending growth. And it will reflect Governor Kasich's view that Medicaid should be a temporary support for anyone who can work. Coverage supports work. Without access to the right care in the right place at the right time, we are all just one untreated illness from unemployment. But being on Medicaid won't get you a better job or lift you up and out of poverty. The real goal is to not need Medicaid. As a congressman, John Kasich voted for welfare reform, but in many ways, the full promise of that reform was never achieved. It was implemented on top of an existing system that was not challenged to change. Now, as governor and in this next budget, the challenge will be to change, to better coordinate the services that are available to get a job, succeed at work, and stay out of poverty, so Ohioans can bounce back and not get tangled in the safety net. These are exciting times, but there are also challenges, including some challenges in healthcare that will test what we're really made of. The good news is this community is well known worldwide for its leadership in healthcare innovation. You're doing as well as anyone. But the bad news is this community also has one of the highest rates of infant death in the nation. That's a jarring contradiction. We have to sort it out. So the economics are actually pretty simple. We get what we pay for. Our predominantly fee-for-service system pays for units of service separately, and here's what it financially rewards. More volume, encouraging providers to deliver more services and more expensive services to get those fees. More fragmentation, because paying separate fees for each individual service to different providers perpetuates uncoordinated care. And no assurance of quality, because fees are typically the same regardless of the quality of care. And in some cases, like avoidable hospital admissions, total payments are greater for lower quality care. These financial incentives are upside down, and they're killing us. The US ranks last among 19 industrial nations related to deaths that are preventable with timely and effective care. The Institute of Medicine estimates nearly 30% of all healthcare spending is wasted, yet Americans receive only 55% of recommended treatments for preventive care. And racial and ethnic minorities receive care that often is of lower quality compared to care received by whites. Who is accountable? What about those infant death statistics I mentioned earlier? Surely someone is to blame. The truth is that many participants in the healthcare system see themselves as victims within a system where they've lost control. Healthcare purchasers, payers, providers, and patients, we tend to blame each other. Even as ourselves, we make decisions that run counter to better health. Instead, let's say we all share responsibility in what's gone wrong with the system, which means we all have a role in making it better. What are the options? Over the past few years, some of these options played out through federal healthcare reform. Obamacare, which was at its core a regulatory response to what was perceived as a healthcare market failure. But that diagnosis seems wrong or incomplete. It's not that the market is broken. It's done exactly what it was designed to do, reward more care instead of better care. The problem is that the fee-for-service system rewards the wrong things. What we really need to do is reset the basic rules of healthcare competition so the incentive is to keep the healthy, pay for what works to improve and maintain health, and convert volume-driven fee-for-service payments into value-based payments that reward better health outcomes. How do we get to value? Again, this community is one of the leaders, and I believe you'll get to value ahead of others. Better Health Greater Cleveland, for example, has been working for years to improve access to high-quality primary care. They are national leaders in advocating patient-centered medical homes. This is a great idea. Primary care practices that have gone the extra distance to become designated as a patient-centered medical home. They coordinate care for their patients across all settings, engage patients in their own care, develop an individual care plan for chronic conditions and preventive care, and provide 24/7 access and same-day appointments. Done right, these practices hold down the total cost of care. But when they do, the value accrues to health insurance plans as avoided costs. And none of the savings flow back to the provider who held down costs in the first place. What if we reverse that flow and get some of the money back to the practices that actually generated value? What if health insurance plans agreed to share some of the savings back with providers who actually keep people well and, adjusted for risk, hold down the total cost of care? Now, this is such a good idea that Ohio's 4 largest commercial insurers, Anthem, Aetna, Medical Mutual, and United, as well as Ohio's 5 Medicaid managed care plans, agreed to align how they financially reward patient-centered medical homes to create a meaningful incentive for practices throughout Ohio to convert. I wish that was all we needed to do, that good primary care would prevent us from ever needing more medical care. But the reality is that about 70% of what we spend on health care is related to just 50 high-cost episodes of care. Today, we pay for all of the inputs separately. A joint replacement, for example, consists of different payments for the surgeon, anesthesiologist, hospital, device manufacturer, rehabilitation, drugs, that's just naming a few. The surgeon doesn't need to pay attention to the cost of the other items and may never know the price of those items because it has no impact on her payment. But what if the surgeon received a bonus payment for meeting minimum quality requirements while also holding down cost? The fact is, many providers are generating this value today, but just like the earlier example, savings accrue to the health insurance plan, not to the high-value provider. Beginning in a few weeks, the plans I mentioned, Anthem, Aetna, Medical Mutual, United, and the 5 Medicaid managed care plans, will begin sending performance reports to the principal accountable providers for 6 high-cost episodes of care. I've seen some of the reports, and the variation is startling. In perinatal, the C-section rate varies from none to 100%. COPD acute exacerbation, the inpatient admission rate varies from none to 67%, and the rate of repeat from none to 63%. Acute PCI, stents, the readmission rate varies from none to 36%, and joint replacement, the readmission rate varies from none to 33%, and there is a greater than 200% variation in imaging and diagnostic costs. After an initial performance period, gain sharing will be available for high-value providers, and each plan will have to make this decision. There may be penalties for high-cost providers. One important point, the episode model adjusts for risk, which means providers who see patients with more complex needs are not penalized because the costs associated with those patients are higher. After the risk adjustment, it is easy to see a correlation between high quality and low costs. This seems backward. We were always taught that higher quality requires higher cost, but that's just not true. And if you think about it, it makes sense. A high-performing team is going to be more efficient and, as a result, more effective in delivering high-quality care. The difference is that now we will be in a position to financially reward them for providing that value, expressed as higher quality and lower costs. I'm well under my time limit. That's a lot to absorb, and I appreciate your patience. We're almost to the point I enjoy the most, which is the open discussion. Whatever comes next, I know the leadership to get there will come from this community, because it always has. What we're trying to do from the state is create an environment where we challenge each other to do better, which means challenging each other to see problems as they really exist, so we can work together to really fix them. As a policy, big finale. As a policy person, the past 4 years have been the most rewarding I've had in 20. I'm inspired by the work I see here and throughout the state, and believe we really can improve overall health system performance. It's exhausting, but I've got to say, after all these years, I'm still motivated by the decency and the urgency and the fearlessness of our governor. It's fear that locks us up and tempts us to blame, but also what drives us to seek community and work together to leave it all better than we found it. Thank you.
Good job. It's a new record. Set the bar. Hello, I'm Dan Malthrop, Chief Executive here at the City Club of Cleveland. It's a pleasure to have you all here with us today. Today we are enjoying a forum with Greg Moody, Director of the Governor's Office of Health Transformation in the state of Ohio. We encourage you to formulate your questions for our speaker now and remind you that your questions should be brief and to the point. Be sure to tune in to our Friday Forums broadcast on 90.3 WCPN, WVIZ PBS 104.9, WCLV Idea Stream, or one of the many radio stations across the region and country that carry City Club programs. Television broadcasts of our programs are made possible by Cleveland State University and PNC. On Friday, January 30th, the City Club will host a panel discussion on the state of cancer care in Northeast Ohio with members of the Case Comprehensive Cancer Care Center. No, just Case Comprehensive Cancer Center, pardon me. For more information about our upcoming and past forums, please visit us online at cityclub.org. Our sponsor for today's program is the Mount Sinai Healthcare Foundation. We thank you very much for your support. Community partners for today's program are the Benjamin Rose Institute on Aging, Better Health Greater Cleveland, and the Center for Health Affairs. We thank you very much for your partnership. We also welcome guests at tables hosted by Benjamin Rose Institute on Aging, Better Health Greater Cleveland, Cleveland Clinic Government Relations, Case Western Reserve University, Medical Mutual, Mount Sinai Healthcare Foundation, St. Luke's Foundation, Sisters of Charity Health System, the Center for Health Affairs, the Metro Health System, and University Hospitals. You all are wonderful, wonderful people. We would like to return now to our speaker. I really mean that. I know it sounded weird, but I really do mean it. I mean it. We'd like to return now to Mr. Moody for our traditional City Club Q&A. We welcome questions from everyone, including guests. Holding our microphones today are Marketing and Outreach Specialist Kirsten Pianka and our Administrative Assistant, Jackie Pawali. Where's Jackie at? Oh, there you are. All right, our first question, please, Mr. Moody. Thank you.
I think Dr. Siebel suggested correctly that this isn't the first time that people have talked about value purchasing, particularly from a state policy perspective. I think you did a nice job of talking about the variations and how those things, those standardizations of care can create value both in terms of quality and in terms of economic value. The one thing I didn't hear, and I'm interested in your thoughts on, is how are the plans going to have a skin in the game? You talked about providers, but you didn't talk about plans. Obviously, my prior experience was to use the plans to do exactly what we're talking about, and it didn't happen. So I guess my question is, how do you hold the plans accountable, and what's their skin in the game?
Sure. Accountability in actually being able to do this is really important. We're lucky in Ohio to have the person who I think is the best Medicaid director in the country right now. His name is John McCarthy, and John is really talented at what he does. We have taken a very aggressive approach with the plans, where in the past there was a somewhat loose relationship, almost a provider kind of relationship like the old fee-for-service system might have had with hospitals. It is a very different relationship. We see the plans as an agent of the state that need to achieve our objectives. So when we worked with the 4 commercial insurance plans to design a new payment model for patient-centered medical home and for episodes, we did it with them because we wanted it to be voluntary and not regulatory for those commercial plans. But the model we designed, we are mandating our 5 Medicaid plans use and implement. And all 5 are on track to do that. Also in our relationship with the plans, we now withhold a portion of what they get paid and only release it to them if they meet quality indicators we set. And we're going to match those quality indicators to the objectives of our payment reform objectives. So accountability is critically important. You have to be not afraid to use the authority you have to act. And I think we're in a good position right now with the plans in that regard.
Okay. Hi, my name is Barb Belovich, and in retirement what I've been doing is working with Medicare recipients through the State Department of Insurance to help them enroll in different Medicare insurance options. And what I found is a very open constituency, folks who really understand their medical expenses, and unlike the younger populations who are busy in work, have a lot of time to spend on this, and they come with bushel baskets full of receipts, and they put them in QuickBooks, and they're very familiar with their expenses. And they've got real skin in the game because staying well is important to them. Obviously, it affects their premiums and their expenses. I wonder if we're missing an opportunity. I haven't heard the patient word used too much today, to enroll this group into an educational process and to start communicating with them about the value-based purchasing and the way in which they themselves can make better decisions and to understand the way in which healthcare is changing. I wonder if that might help the tip and the tipping point.
Yeah, absolutely. And at some point in the future, it will be clear to us that the answer all along was each of us individually making choices to stay healthy. And if we all would do that, many of these issues we're talking about would not be the current crisis they are. I do think in a limited period of time, there are limitations on the ability of government to change individual behavior. Of course, there are things you can do. For example, a cigarette tax has a very quick effect to decrease smoking use. But there are also things that is difficult to intervene at that moment where really it's that relationship between the patient and the patient, the patient and their doctor, where the decision's being made. We've focused in a lot of what we've done on where we have the most control, which is in how we pay, and committed how we pay to support things like patient-centered medical homes, a key component of the design of which is a very rigorous, focused process of patient engagement at the primary care level. So absolutely we want to support that, but also see the limitations in a short period of time of being able to do that. I shared with the earlier group that some of us thought we had 4 years because the kind of reform and change the governor was talking about when he came in was very aggressive and not the kind of thing that typically gets a person elected again. But what we found was there was such a desire for just decisions. Something has happened in the system where it's harder to move decisions through the process. And I think the ability to make some of those decisions and move them, even as it had some folks concerned, it was seen as something that was generally moving the system forward. So we have another 4 years, and I think there are some things we can do, including in the budget the governor releases on Monday, that might move in some of the direction I just mentioned. Yeah.
Chris Morris with the Cleveland Clinic. Thanks for your comments today. Yesterday, Sylvia Burwell, the administrator of Centers for Medicare and Medicaid, made an announcement that by 2018, I believe she wants to do value-based care for Medicare and Medicaid. And I was hoping you could comment on that.
Sure. That's good news. I mean, that the federal government is focused on aligning their payment in that direction. One detail I didn't mention in this work we've been doing over the past 18 months on payment innovation, getting the plans and the providers to commit to a patient-centered medical home model and episode-based payment models. We've built a coalition on a scale that is really unprecedented in the country in terms of the number of people who have been involved. That let us then seek additional federal support to take our ideas full scale. And in December, Ohio was awarded a fairly significant grant to move forward payment innovation, including moving forward past some other large states that in the past have been known for this. One of the keys to that is now that position of taking our ideas to scale as a test brings Medicare as a payer to the table. So what is it that we're doing that Medicare might consider picking up? What is it about what Medicare wants to do that we can incorporate into our models? That's now a direct conversation. I mean, I think there's sometimes some general sense. You were talking about seniors being very aware of Medicare. If they're low income, they also have to contend with Medicaid. And it seems like that'd be coordinated, but it's not. It's long-term care is like a different world from if you need to see your doctor or be in the hospital. So one of the big moves we made in the last budget was to take the Medicare benefit and Medicaid benefit together and coordinate it together so individuals don't have to navigate two totally different systems. We learned in that experience that Medicare is very hard to work with. The design, I'm remembering this is a public event. The design is a national health insurance plan that runs basically the same nationally. Medicaid functions as a state-based plan that has developed somewhat differently from place to place. So the notion of getting those two kind of fully coordinated is not as simple as it might sound. So I'm encouraged that we learn some things through the dual eligible project that now lets us come at payment reform knowing what the Medicare objectives are, not just acquiescing to those, but figuring out how we can bring our reforms in alignment. Because really what you want to do is send a clear signal at the provider level that doing the right sort of thing brings financial reward from Medicare, from Medicaid, from any other payer. And that's really what we're trying to do. We're trying to bring together that clear signal.
Thanks for taking my question, Director Moody. While pay for performance sounds wonderful in theory, a lot of research into pay for performance, including some very large studies, particularly a multi-billion pound one in the UK, have shown very little effect on fixing or changing physician behavior as well as on outcomes. Has the state learned from any of this prior research, or are there any different aspects of this particular pay performance that you expect will help it succeed more?
Sure. I hope so. Absolutely. You know, it's like anything. You know, you can have a checklist and you can say, okay, I'm a primary care practice and now I bought my EHR and I'm a patient-centered medical home. But unless you use the EHR and unless you change how people move through your practice so you understand kind of more about what they need holistically, the EHR is just something running in your back office. So I think there were early attempts at this that actually really turned, for example, insurance against some patient-centered medical home models. And you get how that would work, right? Physicians, primary care would say, oh, this is so hard. With a little bit of upfront money, I'll do better, it'll keep people well, and you'll save money. So insurance companies gave them some money and then saw that it really didn't save them money later and soured on the idea. What we have seen is that where you take a very rigorously structured approach to enhanced primary care, where you have 24/7 access for individuals, so they're not defaulting to the emergency room, where you pay for things like email communication, constantly talking, following up, where you have a care plan that doesn't just check to see if you got the immunization, but actually proactively seeks you out to say one is due. When you do that, it not only saves money, it saves a lot of money. And we had a presentation earlier today from Better Health Greater Cleveland where some projects here that focus in that way are getting incredible results. So if we're loose about it, if we're political about it, let's just let everybody in, we will not get a good result. If we create a high standard and say if you hit it, then you have earned financial reward, I think that has the potential to save money.
Hi, thanks so much. Jean Polster from Neighborhood Family Practice. I wondered if you could comment on a couple of things that really impact our practice in our health center. One is you touched on earlier this morning about changes coming for the behavioral health sector. a lot of resources in community mental health are so separate from the primary care structure. And I'm so excited about the things that you've said about the medical home. How does behavioral health get included? And then if you could also comment on the professional shortages of primary care providers, is certainly an issue I think that is on top of the mind for many of us providing primary care.
Sure. There's a lot there, and all of it really absolutely basic for this to work. Behavioral health care, primary care. You know, the official talk of this is we get what we pay for. Well, that's why we have a primary care shortage. Primary care has never really kind of been seen in the system as a partner in the same way specialties are, because in a fee-for-service system, what does it create a demand for? It creates a demand for the higher cost specialties, not really the lower cost primary care. So the system has migrated us into this highly specialized function at the top of your level rescue medicine, where really we wait until somebody is really sick and then we perform miracles. But we miss the front end. We miss the front end. So how do you get at that? Primary care rates. Stay tuned on Monday. There will be real reforms in behavioral health. Let me say a little bit about that. The behavioral health system in Ohio is going through an unprecedented transformation right now. And what's going on is, a couple of years ago, most people didn't realize this, most adults with mental illness were not under any circumstances eligible for Medicaid. Because to be on Medicaid, you had to have a child or a disability that prevents you from working. Otherwise, under no circumstances, even if your income is zero, were you eligible for Medicaid. Now, because below 138% of poverty, anyone is eligible for Medicaid, this group of adults with serious mental illness now have access to health coverage to cover their health care costs. Who was doing that before? Local behavioral health boards had local levies, your money in this community, where they would bring that in and pay for those services. Now all of those medical and behavioral health services are covered by Medicaid. What do you do with that money? Boards that have a vision for that, housing, employment supports, will become leaders in those areas in their community. Boards that do not have a vision for that, next time that levy comes up, are going to be trying to explain why they're not providing health care anymore. That is a fundamental change. So I think communities really need to think about what about this resource that didn't exist before, that now is available, where the healthcare stuff falls short. What the person really needs is a safe place to live, a stable place to live, some help to get connected to work. How can we do more there? So we're going to include some things in the budget that start to try to draw a line toward that vision for the future, and we hope it builds support to go in that direction with us. It will build some resistance, because whenever you suggest change what you used to do and let's do something better, it creates conflict.
Change is hard, isn't it?
Change is
Mr. Moody,
hard.
thank you so much for joining us today here at the City Club. I wanted to ask you to elaborate a little bit on something you spoke about having to do with outcomes, specifically with those 50 or so episodes that you're most concerned with and the outcomes you're looking for. Who decides what a good outcome is? How do you make that decision? Then how do you decide what that's worth in terms of a payment? And perhaps to make it concrete for all of us, you could apply all of this to something really expensive like end-of-life care.
Yeah.
And really hard to talk about too.
Yes. Yes. That is a great way to pose the question. And I'm not going to avoid end-of-life care, but I'm going to avoid it at first. So who decides what quality means? This is one of these real disconnects. I am the plan, the insurance plan. I am paying you. I'm just going to tell you what I think quality is. That just doesn't work, because then at a provider level, you know, you're trained to know what works. But there's huge variation in how folks actually practice. Everybody's trained well, but we have some providers who do it really different. And some get good outcomes, and some get very poor outcomes. So when we were approaching this question on the episodes, another thing that goes wrong is complexity. If you say, look, hospital, we're going to give you a grade, and as a hospital, you're either good or bad. Well, within that hospital, there are areas of excellence, and there are areas that need to improve. What we tried to do is get down to a level where you could actually look at information, particular episodes, like joint replacement, and say, if we look at all the claims related to this together and certain quality indicators, what do we see? What quality indicators are important? Well, to answer that question, we invited all of the state's top joint surgeons into a room, and we had 30 people over a period of about 12 months sort through how they would practice. And what we said was, set payment aside. Don't say you're going to do this because that's where the payment is. Set that aside and identify an ideal patient journey through this episode. And then once you have it and the outcome, we took that to the insurance plans and said, we want you to pay for this. And they agreed. That's very different than how it's been done in the past. Now within that, there's another issue where, and I alluded to this before, we don't want a situation where a provider says, okay, this person is really sick. They're going to be really expensive. This person's not so sick. They're going to be less expensive. I'll take this person because it'll make me look good on lower cost. That's the opposite of what we want. We want that provider to take the more complicated person and really do right by them. So the episode model risk adjusts. What is it about this person that we should discount that price because we know they're going to be more expensive because of these other things? Factor that out so we can get to what you really have control over for this particular episode. And again, normally the insurance plan would do that and say, here's how we're going to pay you. But we had the joint surgeons in this case go through all of the most relevant factors, apply a weight, and then we took that risk adjustment to the plans, and who knew? They said yes. We did that for 6 episodes, not including end-of-life care, not including behavioral health, because we wanted to start with things that were pretty easy to find, tended to have a start and a finish, and for which there was pretty widespread agreement around what good clinical practice would mean. Behavioral health, end-of-life care, very complicated. When does it start? When does it end? What are the issues? It's as cultural as it is clinical. Those things are very difficult to get to work inside a model like this. Now, I do think there are opportunities, for example, through patient-centered medical homes or through better value or getting these revenue streams together to do better at end-of-life care. But that is one where it is not going to resolve until we have a cultural conversation around what that time in your life means. My wife is a United Methodist minister, and Lori is often the person at a person's bedside who explains to them how much time they have left. The family can't, the providers sometimes don't. There's something not right if we're so afraid of that we can't address that. So I wish government could tell you how to manage end-of-life care, but it can't. And particularly this administration is not going to. So I think that's something that we're going to have to continue to wrestle with, because it's like healthy behavior. Until we accept we have responsibilities from here to here, all of these things are more complicated.
Hi, Director Moody. Pam Waite with the Center for Health Affairs. Just a question related to behavioral health. I know there's changes that'll be occurring at the board level. Are you anticipating any changes now within the state hospital system now that so many folks have Medicaid and outside of forensic beds, of course? But what might that look like, or would more resources come back into the community somehow?
Yeah, well, it's one of the interesting quirks of Medicaid that Medicaid won't pay for a person with mental health in a psychiatric hospital. It's technically an institution for a person with mental disease, an IMD, and they just won't pay for it. So we're looking at some ways to get the Medicaid benefit to be more complete as to what it covers. But currently that is not an option. Now it creates some strange incentives where, think about it, where if you were a county board before and you had to pay for the community benefit, but if that person was admitted to the state hospital, you don't pay for that, the state does. Think what a strange incentive that is to institutionalize a person who really probably should be cared for in the community. So one of the things we really wanted to try to get at is elevate that funding requirement to the state where we can look at it together and prioritize community services as a way to avoid institutionalization. But it's very complicated and interconnected, and stay tuned on Monday because I think behavioral health and developmental disabilities, at least in health policy, are the areas folks are going to be talking about on Tuesday as it relates to the governor's budget.
Hi, I'm Nick Cohen, University Hospitals family physician. I spent this past year working with some of the most complex and highest cost patients at my hospital system, and I needed care coordination. And our payment system only supported fee-for-service and didn't support care coordination. So I reached out to care coordinators who are actually exist. I didn't even know until I really found patients who I could not serve without their help. But what happened next was made me turn away from engaging them again. So the patients I was caring for had 5 different Medicaid care management teams. None of them had access to the patient's records. And I was actually had to choose between caring for the patients and caring for the care management teams. And it didn't seem like the money for care management was going to the right people. And I'm wondering what you think about that.
Yeah. You, out of personal experience, put your finger right on something that we are trying to wrestle with. And it goes back to this inherent, we just can't not think this way, this inherent belief in our system that fee-for-service, I have my lane, and by golly, it's got to happen in my lane. So if what we say is we want better care coordination, suddenly then you have a behavioral health care coordinator, you have the health plan care coordinator, you have the hospitalist in the hospital, you have the primary care plan, everybody's doing the right thing. They're trying to create a better point of care coordination. And then, like you were just describing it, everybody's in therapy because you're all just coordinating each other. So that's a strange result. So what we've been trying to think about, and this isn't right yet, but it's some idea of air traffic control. Because at different points in time, it should probably be a different care coordinator. Ideally, it should be the primary care practice. That should be the default for care coordination. And an enhanced version of that where it's not just the doctor, but maybe somebody, a social worker and other folks embedded in the practice who actually can do some real care coordination. But then if a person has a long hospital stay, not a day or two, because that should still be the primary care as the key point of coordination. But if it's a long hospital stay, maybe it flips over. Or if there's rehab and they're in a nursing facility for a while. You want care coordination to be as close to that person as you can. The plan or the accountable care organization or whatever it is in the future that ultimately is responsible for this pathway needs to think of it not as I am now going to own my own care coordination to control the others. It needs to be I am going to manage the handoffs from one care coordinator to another. Something like that could work. We do not do it. And it's gotten even worse because now that we pay for care coordination in different ways, everybody's just building it themselves. So we're going to do something really interesting related to this, a little bit of an aside, but infant mortality. I chose infant death as I could have picked, you all know them. I could have picked a dozen health outcomes. But infant death in Ohio is really something we have to take a look at. And what we've been doing recently is looking at maps because most babies in Ohio are born fine. But if you look at certain communities, everybody in that community is at very high risk of poor birth outcomes. Well, now there's a place where a plan, because now most of the families in that community may be on Medicaid, instead of the plan hiring a care coordinator and phoning in advice, why not embed your care coordinator in that community? Hire them from that community to connect people to care. That's a very different idea for care coordination. That's exciting. Monday, budget.
Hi, Elizabeth Sump from the Cleveland Clinic. Kind of cycling back on a couple of earlier themes, first around sort of just-in-time delivery of behavioral health services, as well as issues around provider shortages in specialty areas. How do you think the state is going to be evolving its thinking around reimbursement for distance health and telehealth provision of, in particular, behavioral health services, which might be uniquely suited to that sort of delivery?
Yeah, that's a great question. This is a really interesting area. Telehealth. Obviously, done right, it has huge potential to address access issues and also hold down the total cost of care. But I've got to tell you right now, it is being lobbied like the military-industrial complex. Every tech company in the world knows they are the telehealth provider of the future. And it is really spoiling the game. So in this last year, John McCarthy, the Medicaid director, best in the country, opened up Medicaid reimbursement for telehealth under certain limited circumstances. The idea was not to send the signal that we think this is that small. The idea was to start testing to see how it works best, so as we expand it, we do it in a thoughtful way. So absolutely, where technology is changing in a way we can take advantage of, there are real opportunities there. We need a better workforce strategy. We subsidize through our Medicaid program the training of primary care doctors and also cardiologists. I think the market is providing cardiologists, but it's not providing primary care. So can we refocus some of those resources to say, really what we want to train are primary care doctors or recruit minorities into health professions? Why not make those our priorities? And then that ties directly back to the notion of serving people in underserved areas. We'll forgive your loan if you serve there for a while. It all goes together. We started a conversation on the Medicaid graduate medical education. I got to be honest, it didn't go so well. So Monday doesn't represent what I would call a grand compromise. It represents what we are just choosing to do.
Thank you, Greg. Today at the City Club, we've been enjoying a forum featuring Greg Moody, the Director of the Governor's Office of Health Transformation. Thank you, Mr. Moody. And thank you, ladies and gentlemen. This forum is now adjourned.